Good morning, everybody. It's my pleasure to be here, and it's my pleasure to see so many of you sitting here for this basic neuro session. So if somebody tells you brain tumors, they immediately assume that cannot be basic at all. And this is really true. So brain tumor imaging objective will include several things: diagnosis, treatment planning, and post-treatment evaluation. I will try to make it as simple as possible. So let's say I am a neuroradiologist. So basically, if I see patients with brain tumor, the first question is, what is actually my job? What should I tell clinicians, and what should be in my report? So first of all, I will have to make the right diagnosis. I will have to tell them, is this really a brain tumor that they assume, or could be something else, a non-tumoral lesion? If possible, I would like to tell them if this is a benign lesion, a benign tumor, or malignant. And if possible, I would like to tell them even which grade. Concerning treatment planning, a neuroradiologist is the one who will delineate tumor for a peritumoral edema and exactly tell clinician who will radiate it where is the place to radiate and which part of this tumor should be taken out. And finally, after treatment, I should be the one to tell them, is this new tumor coming up, or is all what we see abnormalities on MR or CT just a treatment effect? So how are we going to actually answer a lot of these questions that I listed here? So the brain tumor protocol is actually a long one with a lot of conventional and sophisticated techniques. Such a brain tumor protocol would go like 45 to 60 minutes, and it's a jungle of sequences. So what should you do? So this will be outline of my lecture today. What I'm going to teach you is what is each of these techniques telling you about the tumor, so that finally when you put everything together, you will be able to make the right diagnosis. And we will start with something called conventional sequences. What do we mean under conventional? Conventional means just plain T1, T2, and the flare sequence. So the first thing, when you open your PAC station, you look at image in a patient of a brain tumor, you will have to see what is the brain tumor itself and what is actually peritumoral edema. So what is peritumoral edema? It's actually a result of a hydrodynamic pressure on the peritumoral brain tissue. It's not a tumor itself. It is a glial cell reaction to the tumor, and it does not correlate with size or with histology. If you look at these two patients with two tumors, both are grade 1 tumor, which means a very benign lesion. One is having almost no edema, and the second one is having a prominent edema and mass effect. So no answer about actually histology or sign. Necrosis. Necrosis is usually a bad sign. It's a sign of malignant tumors, and it happens due to the sudden occlusions of vessels. So we have a malignant tumor vessels and then thrombosis, which are predisposing factors. It is a poor prognostic sign. How do you diagnose necrosis? Necrosis you diagnose if you see parts of the tumor which will be low on T1, high on T2, and which will not enhance. It is a very common scene in malignant glioblastoma multiforme, such as these three cases. You see peripheral enhancement and a central non-enhancing part, which represent necrotic tissue. What about calcification? Are calcification telling us anything about the tumor? Well, they're usually a benign sign, of course not always, and they're best seen on CT. The calcifications cannot tell you if this is benign or malignant tumor. So you see all these tumors in posterior fossa located in the middle. One is grade 1, grade 2, and grade 4, and the calcification always look the same. Calcification can be small puncture or can be very big in tumor, but still they will not tell you which kind of tumor that is concerning histology. What about cystic parts? Well, this is important. This is important with neurosurgeons. You have some tumoral cyst, which is this one, and you will diagnose it if you see a cyst that has actually enhancing walls. And some cysts will just be reactive cysts, and they will be called non-neoplastic cysts. They are reactive cells arise in neighboring tissue, and they will not have an enhancement. What do you think? Is cyst telling us something about the tumor, about the histological grade? Unfortunately not. I'll put here ependymoma, which is a grade 2 tumor, and medulloblastoma, which is a malignant grade 4 tumor. And both have intratumoral cysts with enhancing walls. So you cannot count on peritumoral cysts to be able to predict the histology. Even if you see a completely cystic tumor with enhancing wall, you cannot tell based on this if it is glioblastoma or maybe just craniopharyngioma. Hemorrhage will be seen relatively rarely, and it's also a bad prognostic sign, and it's due to pathological changes in vessels. Very typically, and you all know that, will be seen in melanoma metastasis or some other metastatic disease. We would like to summarize these very simple things that I know that you all describe when you see a brain tumor. Then all these things are actually non-predictive of grading. Neither size nor location, edema, necrosis, calcification, hemorrhage, cyst. Based on this, you cannot predict if this is malignant or benign lesion. So it's obvious that we need something more. So the next step would be gadolinium-enhanced study, which I know you all do. What does it mean? What am I looking in a post-contrast scan? What I'm looking at a neovascularization. That immediately tells you I'm looking if there are new vessels, and if these vessels are very pathological, and if they do have disturbed blood-brain barrier. Normally, low-grade tumors, especially brain tumors, will show no enhancement, like this diffuse astrocytoma, because they have vessel with intact blood-brain barrier. This would be a DNET, which is a tumor in children associated with epilepsy. Low-grade tumor, typically non-enhancing. High-grade tumors will enhance, sounds logical. So glioblastoma, lymphoma, anaplastic, so all 3 and 4 grade tumors will usually enhance. Of course, nothing is 100% to make this our life maybe difficult and maybe interesting. You will have some low-grade tumors that will still show intense enhancement. This is like meningioma, which is typically a grade 1 tumor, plexus papilloma, or ganglioglioma. Which means actually that there is no correlation between the degree of enhancement and the tumor histology or grading. Means we need to go further in this tumor protocol to something called perfusion MRI. To understand what is perfusion giving you for brain tumors, we have to go a little bit back into pathology or pathophysiology. So we have terms called vasculogenesis, arteriogenesis, and finally angiogenesis. And that is exactly what we're looking at when we're talking about brain tumor. What does it mean, angiogenesis? It means development of new arteries from pre-existing ones. These are new tumor arteries. They are definitely different than the normal ones. As a general rule, the more aggressive a neoplasm, the more abnormal the vasculature. So these vessels are very tortuous. We have more vessels, we have a higher tumor blood volume, and greater permeability. And that is what we will see on perfusion. Let me just show you this from a very nice study in radiology. It's a tumor in the frontal lobe. And if you look at these blue and yellow vessels, these are the normal vessels, relatively regular, smooth walls. Let me show you and zoom for you these vessels in the frontal lobe. You see, they're very tortuous. They do not have these nice and smooth walls, so they are very different tumor vessels. So low-grade tumors, we have low perfusion because they still don't have these pathological vessels. Again, the same example that I showed you before, DNET, as a low-grade tumor, will show on this cerebral blood volume map actually a low perfusion. Let's say simply it will remain blue or dark. The more red it is, the more vessels you have and the higher perfusion. If you want to do it even better in small lesions, if you're not sure what are you looking at, you can even overlay this perfusion and a T2-weighted image so that you're sure what are you looking at. This is grade 2 astrocytoma. Again, low-grade tumor, non-enhancing, on a CBV map on the right side, low perfusion. These are 2 tumors located in corpus callosum, which is very typical for astrocytoma or glioblastoma. Here, there is a difference. You see grade 2, which has a low perfusion, and grade 3, which all of a sudden has these red parts of the tumor. So it must be something that happens in this tumor between grade 2 and 3. And this is called angiogenic switch, which even if you don't know what it is, just the name tells you something is happening to the vessels between grade 2 and grade 3. And this will be visible on this perfusion. And finally, if this is a grade 4 tumor, all the solid parts of the tumor that are enhancing will show high perfusion because of a higher density of all these pathological vessels. So low-grade glioma in the upper row will have no enhancement, low perfusion. High-grade glioma will have enhancement, and a lot of these red parts, they're representing actually increased perfusion. So this is grade 2, grade 3 again, and grade 4. You can't really see the difference between 3 and 4, but definitely that is what happens, the process, and the most important thing is between 2 and 3. There are some exceptions to the rules, of course, the same as in talking to T1 with gadolinium. There are some benign tumors that somehow behave a little aggressive on perfusion, and those you just have to know. I will just show you a few examples. Oligodendroglioma tend to look as a very malignant tumor, but it's actually not. Or a central neurocytoma. It shows parts with increased perfusion, but again, it's a low-grade tumor. Or just a simple meningioma that I'm sure you have seen. Usually they're very red on this perfusion map, high perfusion, but it's a low-grade tumor. So these exceptions, of course, you will need to know. Lymphoma is something different. It's a very malignant tumor. I'm sure you know that. So why is lymphoma then not having increased perfusion? Because lymphoma is a highly cellular tumor. You don't have a lot of tumor vessels. You actually have a lot of tumor cell. That's why lymphoma will very commonly remain dark on this perfusion. So there are certain rules and certain exceptions. If we want to summarize without going into details, the neoangiogenesis, these new vessels, this is considered one of the key features of a tumor. So this is now predictive of grading. So now we came to the first sequence that actually tells you something about the grading, and this is perfusion-weighted imaging. There is something that is used more and more that's called susceptibility-weighted image, or SWI. Why that's so? This sequence is sensitive to blood products and is nicely showing you vessels. So if this is true, then we can assume that this sequence will show us pathological vessels, and that is actually true. So again, this is a low-grade tumor that you see here that is even enhancing a little bit. But if you look at this SWI, there are no many pathological vessels. So low-grade tumor. This is glioblastoma grade 4. Look at this. All these lines and tubular structures and dots actually do represent the vessels that we were talking to. And that is actually consistent with all these red parts with increased perfusion. In a glioblastoma, look at this one. If you see a huge tumor like this that is as dark as SWI, that this is almost diagnosis histologically to be made. A mass spectroscopy is something very nice, maybe takes some time, and it's a little complicated out of all these sequences. I will make it very simple. There are basically two things. There is a normal angle and there is an abnormal angle. This is a normal angle that has NAA, and then it goes down to creatine and choline. This is the reverse angle, or we call it tumor angle, and it looks exactly opposite. The highest is the choline, and then it goes down. It's as simple as this one. So low-grade tumors have a tendency to have a higher choline, but it never goes very high. It's just a little bit high. NAA is low, but it's still visible. If we look at the angle, this would be the normal one, and that's pathological one, but it's not really very steep. If this is a high-grade tumor, then a tumor angle really looks very steep, so very, very sky-high choline in comparison to the normal one. Let me go back to that case that I have shown you before. Again, low-grade astrocytoma, no enhancement, low perfusion, and an atypical tumor angle. This is there we have some exceptions and some little problems in this. And the problem is that this tumor angle, as I just described, it's not only specific for brain tumors. So it could be seen in neonates. It could be even seen in acute ischemia. So be very careful. That has a low specificity. To be very careful with this, that's why neuroradiologists do multivoxel spectroscopy. Even the name tells you, multivoxel. So we put many little voxels or boxes when we look at MR spectra. And what is then important, you put one of these little boxes in tumor and the next one on the other side in a normal appearing white matter. And what you basically look is this choline peak and choline peak. You look how high is actually choline peak in comparison to the normal one. So you don't look only at the tumor angle itself. You would have to know, is this choline really sky high or just a little bit high? And to know that, you have to compare it with something which is actually normal. So I think it's clear, without going into details, that all this information about tumor biology and metabolic information are actually predictive of grading. So next sequence that is predictive of grading after perfusion is MR spectroscopy. And if you could do both of them, actually that would be perfect. So just, again, general rules. Benign lesions have lower choline than the malignant one. Benign lesions have lower perfusion than malignant one. By combination of these two parameters, you have a very high sensitivity and specificity in preoperatively grading tumors. finally have diffusion and DTI. So when we know everything about the tumor, so why do we need diffusion? Is there any additional information that we can get? Yes, we can, and that is about cellular density, which is also very important. Not only vessels or necrosis, how many cells and how dense they are. If you look at the conventional sequences, you will not be able to tell that, so that is why you need diffusion in brain tumor protocol. If you look at this ADC map, some they look very white, some look dark, and some are very heterogeneous. So what is the deal? Low-grade tumor usually have a low cellularity. Low cellularity means high ADC. This is always the same case that you have seen today. It will remain dark on diffusion and have high ADC. If this is a highly cellular tumor, and a perfect example for that will be lymphoma, then it will be bright on diffusion and low ADC. Very important diffusion-weighted imaging for distinguishing of a posterior fossa tumor in children. All of you know, if you learn for the boards, it just has to happen immediately. When somebody says to you, children and posterior fossa tumor, then you go pilocytic astrocytoma, ependymoma, medulloblastoma. And they all somehow look the same. So how should we distinguish them? One possibility will be to look at this ADC, which directly correlates with histology. Medulloblastoma has the highest cellular density and will be dark on this ADC. Pilocytic astrocytoma has the lowest cellular density and will be bright. Let me show you a very nice example of anaplastic medulloblastoma, which is almost glowing on this diffusion and low ADC, and this pilocytic astrocytoma, which is on the other side of the spectrum. So it looks like this is also very important, and cellularity is also one of the key features of a tumor and is certainly predictive of grading. And finally, besides diffusion, you all know this. You will see many lectures in neuroradiology. Neuroradiologists love these spaghetti pictures on these fiber tracts. And if you have them in different colors, you know, of course, where they're going up and down. And then you can ask yourself, do I need this for brain tumors to know where the fibers are going, of moving? Well, it would be very beneficial if you would look at what is the tumor actually doing to the fibers. This will give you additional information. It's fibers normal, or maybe just displaced, or even disrupted. So by looking at something like this, you will see a tumor that invades the corticospinal tract. So if this is normal, so that looks somehow abnormal, even if you cannot really explain it. This would be displacement, this would be tumor infiltration, just as an example, or disruption of fibers. So obviously, by doing this long tumor protocol, we have a possibility to give a lot of information about the tumor. We can definitely predict the tumor grade, or what will happen in a tumor that will tell us this is increasing. It will increase in cellularity, which will be seen on T2 and diffusion. It will show some necrosis. It will increase the vascularity. You have enough sequences to prove that. And it will increase metabolic rates and cell proliferation, for which you will have spectroscopy. So this would be an example of a low-grade tumor with all these techniques, and this will be a high-grade tumor that we went in details. So now this is no jungle of all this, and now you have listened to me, and this shows this, and this shows this. But how do you do this in your everyday life? You have to have a scheme, you have to have an idea, or a roadmap. Well, a roadmap is something that is published like this, and with this I will finish my lecture. It was published in Radiology already in 2007 as a little help how you go through this jungle to come to the end. And I will show you two examples how this could be done. You look at the brain tumor and you answer, you go like a cascade from one box to the other. So the first box is this tumor enhancing? Answer is yes. So you go here. Then you look at diffusion, is diffusion increased or decreased? And then you go down. What is happening to perfusion of this tumor? It's definitely increased. So you know you're dealing with a high-grade neoplasm. And then you do spectroscopy, and then you will know this is a high-grade glioma. So there is a cascade how to do what. This would be a second example. So is this tumor enhancing? Yes. Then you go to diffusion. Diffusion is elevated, so it must be a necrotic tumor. Then you go to perfusion. Perfusion is increased. And then even that, you could even distinguish glioblastoma from metastasis. You have come to the end of a high-grade neoplasm, and then you do spectroscopy of edema, not even a tumor itself. So you go really deep into details, use all these techniques, and this will tell you that you are dealing with a metastatic disease. I hope it doesn't sound too complicated. I'll try to make brain tumor jungle protocol as easy as possible. So where are we? I started by questioning, I'm a neuroradiologist, what is my job? And of course I place myself in the middle, which all women do because they're so self-centered, isn't that true? So, but no, in a brain tumor board conference, so what is my role? What am I giving information to all these people sitting there? So I will definitely tell the neurologist, yes, this patient is having a brain tumor, and that's a reason for his clinical symptomatology. For neuropathologists, I will be maybe able to tell the neurosurgeon, this is a place where you should biopsy, because this will give you the best sample. If you biopsy necrosis, it will not give you anything. To the neurosurgeon, I will be able to say what should be taken out. To say, listen, this is tumor cyst, and this is not a tumor cyst. This is just edema. And to radiation oncologist, where should he radiate it, and if there's any additional tumors. And once they are done with all this, when the patient comes back later, I think then we are really important, because we will be the one to tell this is tumor coming back, or these are just therapy phenomena. I hope you agree with me on that one, that we should be in the center of this, and thank you very much for listening.